Okay, so I think we can get started. Welcome everyone to the second part of our webinar on empowerment in context, conceptualizing, measuring, and advancing women's autonomy and agency. My name is Caroline Moreau. I'm a professor at the Bloomberg School of Public Health at Johns Hopkins University and the director of research of the William H. Gates Institute at Hopkins. So today I'm delighted to welcome three wonderful, illustrious speakers who will talk about the dynamics of empowerment across time and context. We'll start with Shannon Wood. Shannon is an assistant professor at Hopkins and part of faculty at the Gates Institute. Her work lies at the intersection of social determinants of women's health and sexual and reproductive health outcomes with a specific focus on gender-based violence and reproductive health coercion. Shannon was a senior advisor for the PMA, Performance Monitoring for Action program. And in that capacity, she was instrumental in developing one of the measures we will be using, the Women's and Girls Empowerment in Sexual and Reproductive Health Index. Today, she will be discussing how sexual and contraceptive empowerment shift over stages of the life course and how they connect to opportunity structures and specifically wealth, education, and access to the healthcare system. Next, I will call in Linnea Zimmerman. So Linnea is an associate professor at Hopkins. She was the Associate Director of Research for the PMA project and also the principal investigator of PMA in Ethiopia, which mostly focused on maternal and newborn health. Among Linnea's many areas of interest, she's developed a portfolio that is related to empowerment across the life course, starting in early adolescence and throughout different stages of the reproductive life course. Today, she's going to be sharing some work she did with a master's student, Haley Space, on the role of sexual and reproductive empowerment on demand generation for contraception, as well as the predictive role of empowerment on contraceptive uptake. Last, I will call in Carolina Cordona again. Carolina joined us in the last session where she presented a measure, a cross-country measure on economic empowerment. And today she will be discussing how economic empowerment changes over time and the role of contraception uptake on women's economic empowerment. Carolina is a research scientist at Hopkins. She's trained as a health economist and works at the intersection of economic demography and health. She's also right now coordinating the scientific program for the ICFP program in the next conference in October. A very busy schedule, so many thanks to Carolina for joining us again today. Before I hand it over to Shannon, I'd like to take just a moment to acknowledge some of the discussions we had last week and kind of remind us about our Gates Institute program of research under the leadership of our former director, Amy Choi, who championed this agenda to embark in a quest to understand, on the one hand, what is empowerment, which we discussed last time on related to the foundations of measuring empowerment. And today we're going to focus on who's empowered, in other words, what are the drivers of empowerment, and why empowerment matters for women's health and well-being. I want to thank again the Bill and Melinda Gates Foundation, who supported much of the work that will be presented today. I will also pause again because I just forgot to tell you that this session has a translation and that you can reach for a translated version in French by looking at the chat. And I'll just say it in French for our French collaborators. Cette session est disponible en français. Regardez dans le chat pour avoir accès à la traduction. Merci beaucoup. Sorry for the interruption. You're also very welcome to post questions in the Q&A or chat, and we'll try to respond as we go. But this time around, we hope to have enough time at the end of this session to also address some of your questions live. So again, as a reminder, last week we were joined by Dr. Elizabeth Omoluabi, Celia Karp, and Carolina, who discussed the process for developing conceptually grounded and locally salient measures of sexual reproductive health and economic empowerment. And they walked us through the validation process for both of these measures that are employed in global context. Their work, as well as the research we will be discussing today, is very much made possible by a common project and platform, the Performance Monitoring for Action platform, which brings together global partners in Africa and Asia to collect high quality, rapid turnaround, representative, and longitudinal data to monitor progress around women's reproductive health and well being. And one of the critical features of this network is its strong collaborative commitment to innovation and measurement. And one of those applications is the Women and Girls Empowerment Project. Some of the contributions we shared last week from the PMA platform and related to the Women and Girls Project are summarized here in the slide and will be made available in the coming days on our website from the Gates Institute. And now, with no further ado, I'm going to turn it to Shannon, who will share perspectives, a life course, and research dimensions of sexual and reproductive health empowerment. The floor is yours, Shannon.
Excellent. Thank you so much. Thanks to everyone for joining us. Okay, so I want to start here, and I know that this framework was presented in our last session together, but it's really important to ground sexual and reproductive health empowerment within our framework. And I know that there are a lot of different frameworks floating out there, but a few things that I want to point out here. It's that, first of all, we do have this life course perspective at the bottom, progressing from adolescence, young adult, middle age to older age. We also include a socioecological model and thinking about societal to individual level contributors. And at the top, we have our resources and opportunity structures. And today we'll be focusing a little bit more on the life course perspective, also on that resources and opportunity structures. But let's focus for just a moment here on this middle section. So we really see empowerment as a process, starting with the existence of choice. So whether or not that choice exists in the first place, goals and motivations related to reproductive health outcomes. Then this moves into exercise of choice. I think you all heard last time about just how difficult this dimension is, how there are these self-efficacy, confidence components, negotiation with partners, with family members, with others, and also this decision-making process. And so we see these all intertwined as exercising choice. So once that choice exists in the first place, then you can move forward to exercising that. And then agency is this really active component that's thinking about that progression from exercise to achievement of choice. The other thing that I want to point out with this framework is that we distinctly divide our sexual and reproductive health outcomes. And so our outcomes that we focus on specifically are sex by choice, contraceptive use by choice, and pregnancy by choice. The pregnancy by choice piece is very complicated. We don't focus as much on that, primarily because in our initial validation pieces, we didn't have clear subscales emerge for this component. We realized that we needed to do a lot more research surrounding this. But we have had some really distinct subscales emerge for both sex by choice and contraceptive use by choice, which is where we'll focus today. And as you'll see very shortly, these are really distinct components, really distinct outcomes. And so it's important for us to separate them out. Next slide, please. So as a recap, these are our dimensions of empowerment in sexual and reproductive health. In our cross-site validation, um, we found 6 items that loaded specifically for sexual empowerment. 3 of those were an existence of choice. 3 of them were an exercise of choice. And in contraceptive empowerment, we have 8 items total. 5 of those are an existence of choice, and 3 of those are an exercise of choice. So I'll just pause here for a minute to let you take in the items. But as you can see, the existence of choice are, some of these are about kind of repercussions, motivations surrounding use or sex in the first place. And then the exercise of choice pieces are really, again, about that decision-making, negotiation, self-efficacy components. So we do very much try to divide these out. Next slide. So here you can see our sexual versus contraceptive empowerment scores. I apologize that this is a bit hard to see, but that dark gray color is the contraceptive empowerment score. The middle gray is the sexual empowerment score. And then that lightest gray on the far right is our combined SRH empowerment score. And what we see is that these are pretty clear dimensions. You can be empowered in some realms and not necessarily in others. These do really differ. Overall, our empowerment scores were lowest in Niger and highest in Kenya. And importantly, contraceptive empowerment was higher than sexual empowerment in all of our sites, and really just reflector of some of those gender power dynamics, and also thinking about demand generation programs and campaigns that have really strongly focused on contraceptive use. Next slide. So here, as I was saying before, sexual and contraceptive empowerment are really distinct. We see that across our sites, 23 to 34% of women report both sexual and contraceptive empowerment. And 34 to 42% of our sites, they have little sexual empowerment. So report no sexual or contraceptive power. And then 32 to 42%, they report one or the other. And so importantly, you can be empowered within one domain, but not necessarily within the other. And it's really important for us to separate these out and really tease out these differences when we think about who is empowered. Next slide. So now I want to point out some of those life course and resource differences that we're seeing. So importantly here, we start with parity, and we see very similar trends for age as well. But overall, we're seeing that empowerment increases with parity. There is one important difference. We see some declines actually in Uganda. So this is in sexual power. And so it's really important for us to separate out our sites and really think about these as distinct differences here. But overall, we're seeing that empowerment is increasing over the life course with both age and parity. And a few quotes that I want to point out here that are just illustrative of this. This is from our initial scale development phase. But from Kano, Nigeria, a woman says, "A childless wife is like an empty house, it's useless." And then marital status also introduces another realm of complexity. So we here have a woman who said, "Clinics turn me away. They say contraceptives are for married women, but I need protection too." So this was an unmarried woman. So just thinking about how these life course differences, marital status, age, parity, all influence the amount of choice that women have in the first place, and also how they could exercise that choice. Next slide, please. So thinking about resources and opportunity structures as well, we see here that empowerment increases with both education and wealth. We include the wealth, but just to say that education follows very similar patterns, where across all of our sites, we are seeing increases in both sexual and contraceptive empowerment with increasing wealth. Again, these are some quotes from our initial work. So one woman said in Uganda that savings let me pay for injections quietly. My husband opposed spacing, but I acted. So she had the money that she was able to really exercise her choice in that situation. Second quote is one from a woman in Ethiopia that says, even if I refuse while he wants to have sex, he could not give you money to buy what you want in your home. But if you accept his willing and have sex, he gives you whatever you want. And so in this case, it's really thinking about like that negotiation, that bargaining power that potentially comes with money and potentially with sex as well here. Next slide. Very similarly here, we think about healthcare resources as enablers of sexual and contraceptive empowerment. So overall, this is past year contact with the healthcare provider. We see that overall, this is higher for women who report contraceptive and sexual empowerment, and same with media exposure to family planning messages. Next slide. I think we're at, okay, a few key takeaways here. So we've really found that our ongoing research, thinking about who's empowered, thinking about some of those opportunity structures and life course perspectives have really confirmed our initial women and girls empowerment and sexual and reproductive health theoretical framework. And we do see that empowerment is lying at that intersection of agency and resources. We're also very much seeing that SRH empowerment evolves over the life course and is also conditioned by some of those social capital and resource and social norms components. So at this point, I will go ahead and turn it over to Linnea Zimmerman. Thank you.
Thank you, Shannon. I'm Linnea Zimmerman, as previously introduced. And so for today, I am going to be discussing a little bit more of the associations we see between some of these empowerment measures, and I will be focusing specifically on contraceptive empowerment and family planning contraceptive behavior over time. All right, next slide, please. So, as discussed both in this webinar and the previous webinar, these measures were really grounded in understanding this relationship between or women and girls' sexual and reproductive health empowerment, and particularly contraceptive use. And so the measures were really designed to understand these really specific concepts about empowerment. And one of the first things that was done was to assess, do the measures as designed, are they associated with the outcomes that we would specifically hope that they are associated with? And so this is work that was led by Celia Karp, who presented in the previous webinar, but this is just showing cross-sectional association. So this is saying, women that were interviewed in, let's say, 2022, this is their empowerment score at that time and whether or not they were using contraception. And so we can see across every single country, except with potentially Nigeria, Lagos, that as the contraceptive empowerment scores increase, contraceptive use increases as well. And the relationships might differ a little bit. So for example, in Burkina Faso, we really see that there's kind of a large jump between those who are in the lowest contraceptive empowerment score versus those that are in the second or third tertile. Whereas in Cote d'Ivoire, there's a large jump, but there's sort of a continued increase. And this is across all countries in which there's a PMA survey, and it's and the relationships are fairly consistent over time. Again, a little bit of a difference in Lagos, but still we see that those in the lowest empowerment tertile have the lowest contraceptive use, and those above that lowest tertile have higher use. Next slide. So we want to see if these two domains of the contraceptive empowerment index, so there's the existence of choice, whether or not women feel that the choice to use contraception is even an option for them, as well as the exercise of choice. If they have made that choice, if they have decided they would like to use contraception, are they actually able to exercise that choice or achieve that choice? Then we want to see both if the existence of choice and if the exercise of choice are associated with contraceptive use, again, by choice. And this is after controlling for sociodemographic characteristics, such as the ones that Shannon just went over. We see that across most countries, there is an association. So in Cote d'Ivoire, Congo Central, Kenya, Niger, Nigeria, Kano, and so in those countries, there is an association of both existence of choice and exercise of choice. And then we see in Burkina Faso, Kinshasa, and Uganda that there's an association between existence of choice, but we don't see as clear of an association with the exercise of choice. And then again, we kind of see that in Lagos, these relationships aren't as clear there. And so a little more work is going to be done looking at why are we not seeing these associations as clearly in Lagos. So to the next slide, yes, here. So the main question that arises from this, of course, is if we're looking at this cross-sectionally, we can't really disentangle is greater empowerment leading to contraceptive use, or is contraceptive use leading to greater empowerment? Both things probably are true. And so in some sense, we know that both of these things are related. They are both true, but we really want to disentangle to the extent that we can, whether or not these measures are actually associated with differences in behavior. So next slide. So I do want to just say, I think all of us here, I hope, agree that empowerment of women is in and of itself a worthy goal. It's something that we should be working towards. But for those of us who are in public health, we are also interested in understanding how the relationship of empowerment is actually associated with health behavior. And so that's why we are particularly looking at contraceptive use. So this is longitudinal work that was done with a master's student here at Hopkins, Haley Spieth, and I'm not sure if she's here, but she did the bulk of this work as part of her master's essay, and then we're continuing to develop this for a publication, so hopefully will be out for others to see. But we wanted to ask two questions using longitudinal data, and we'll talk a little bit more about what data set we used in a moment. But the first was, does existence of contraceptive choice correlate with contraceptive intention? And so in PMA, we ask women, do you intend to use a method in the future? And we would think that if women see that there is an existence of choice, that this is an option for them, that we might see that that correlates with intention to use. It's not one-to-one. Women might see that there's a choice and choose not to use contraception. But still, we would think that those two would be sort of linked, and that we would see this is sort of the demand side of demand and access, these two components of use. The second question we asked was, does the exercise of contraceptive choice, and this again is thinking about if a woman has decided to use, is she actually able to achieve that choice? Does the exercise of contraceptive choice predict use of contraception amongst women with an intention to use? And so that's where we were really looking at longitudinally, if women have an intention to use, do these empowerment measures predict whether women are actually able to take that intention and operationalize it into use? Net of all these other factors like education, employment, wealth, etc. So next slide. To do this, we used longitudinal data from Uganda. And so the PMA survey, very briefly, is designed such that a sample of women was selected in phase one. A year later, the same women are selected back into the sample, and any women who have aged into the sample. So the eligibility is women aged 15 to 49. So at phase one, there were 4,793 women who were aged 15 to 49. A year later, the survey team returned back. If women were 50, they had aged out of the sample, they were not interviewed again. But if a woman had been 14 at phase one, she was 15 at phase two, she was then included in the sample, and etc. So we use in this analysis, we're looking at data from phase two and phase three. And the reason that we started with phase two or wave two, same thing, phase two and wave two, the reason that we are using observations of women at wave two as our baseline is that was the first wave in which these empowerment questions were included. So at wave two, our sample, and this is looking at the relationship between exercise of choice and intention to use. Our sample was all women who completed the Wave 2 survey, who stated that they did not want to become pregnant in the next 2 years, and said that they were not using any method of contraception, and that includes the traditional method. So when we apply those criteria, our sample is about 1,000 women, 1,069 women. And then when we go to sample two, which is looking at whether or not the exercise of choice is actually associated with the adoption of contraception, then our sample goes from these 1,069 women to an additional restriction of those who participated in wave three, and if they said that they intended to use a method at wave two. So our first analysis is looking cross-sectionally again at wave two. Do women who we're looking at the association between the exercise of choice and whether at wave two, women cross-sectionally say they intend to use a method of contraception within the next year. And then our second question is looking at amongst those women who said they intend to use a method, do they actually adopt a method by wave three? So next slide. And we see that, in fact, there are very strong relationships. So the crude odds ratio in blue, this is not adjusted for anything. And then we have the adjusted odds ratio in white. And we see that both the existence and exercise of choice are associated with an intention to use contraception. And so we see if women, these are again, amongst all women who say that they do not want a child in the next 2 years, then there is a greater intention to use contraception as women have higher scores for existence of choice, exercise of choice, and the two domains combined together. And this is both when we do not control for anything and when we control for age, parity, marital status, education, and wealth of the woman. And so what we call this the intention gap in this idea of women are saying they do not want to become pregnant, they are sexually active, and then there's this gap perhaps for some women between not wanting to become pregnant and intending to use a method. And so we want to understand what is this gap between saying you don't want to become pregnant, but you also don't intend to use a method. For some women, that may be a very logical, rational choice. They simply do not want to use a contraceptive method. But for other women, it may be that they don't perceive that they have a choice or an option. And so we're really trying to narrow in on those women. And here we see that this is related to empowerment. And we do see that women who are more empowered are more likely to say they do intend to use a method. Next slide. And I think for those of us in the public health field, this is a great slide because we also see that, in fact, empowerment is not just associated with the intention of a health behavior, it is actually associated with the adoption of the health behavior. So in this case, we see that the exercise of choice is also associated with contraceptive uptake 1 year later. So remember, our original sample is women who said they do not want to become pregnant and they are not using a method of contraception. And then we limit this one to women who intend to use a method. And we see that amongst women who intend to use a method, the exercise of choice is strongly associated with the use of contraception 1 year later. Here we don't see the existence of choice is associated, and that's partly because we saw existence of choice is associated with intention, and then once we control for that intention by only restricting to that sample, then it's really exercise of choice that is predicting whether or not women are able to use a contraceptive method. And conceptually, this makes sense and is in alignment with the framework. We do see that the entire contraceptive empowerment scale, when you combine the two domains together, that scale too is associated with contraceptive adoption. But this is very much driven, again, by this exercise of choice and understanding whether women are able to make or are able to achieve a choice once they have made it. So next slide. So the key takeaways, we do see that empowerment measures show both a cross-sectional association and a longitudinal predictive association. We see cross-sectionally measures are associated with intention, and the existence of choice is more closely associated with intention to adopt a method of contraception. And then we see that amongst women who say that they intend to use a method, 1 year later, the exercise of choice predicts that adoption and is more closely associated than the existence of choice. So these conceptually make sense. They're in alignment with the framework, and we do see that empowerment is strongly associated with contraceptive behavior. But of course, we're not done. So first, we need to publish this paper. But we also want to see, are these relationships consistent across other countries? Do we see variation, especially in countries where the empowerment measures weren't as strong cross-sectionally? So for Lagos, for example. We also do want to see whether any of these relationships vary by relevant sociodemographic characteristics. And so going back to some of those life course predictors that Shannon was talking about, is this effect stronger or weaker for women who have lower parity or for younger women, for example? And then finally, we do want to assess over a longer time period. When we did this original analysis, we only had access to phase 2 and phase 3. But there are additional waves that have been completed, and so we'd like to see if these associations are as strong over a longer time period or if they're attenuated over time. So that is, I think that so far our preliminary work looking at how empowerment is associated with contraceptive adoption. And with that, I will hand it over to Carolina to talk about whether whether contraceptive adoption is associated with empowerment. So go ahead, Carolina.
Hi everyone, thanks Linnea. I'm Carolina Cardona and I'm going to continue presenting on the work on women's economic empowerment that we've conducted at the Gates Institute. And last time, as Caroline explained earlier, I presented some of the analysis that we've conducted to validate our metric on women's economic empowerment. And today I'm gonna be presenting some of our preliminary results that are looking at what are the correlates that at one point in time are correlated with increases in women's economic empowerment, and then over time, what are the correlates that enable women to gain or to lose empowerment, and a brief discussion of why it matters for reproductive autonomy. So next one, please. Just to make sure that we are on the same page, I'm just going to start by showing this table that if you attended our last webinar, you saw it in the presentation. And these are the two domains that we use for our economic empowerment scale. The first domain is related to women's participation in making household decisions. And for our scale, we ended up retaining 4 items in which women reported that they are empowered if they participated in the purchases of large items, daily necessities, medical care, and clothes. And the way that we coded this variable is that she was empowered if she reported that she was the sole decision maker, or if she and her partner made the decisions together. She was not empowered if the partner was the sole decision maker or if someone else was making those decisions. Just to reiterate that we did do a bunch of sensitivity analysis to the way that we coded this variable, and these are available in our metrics paper. Now, the other domain that we looked for economic empowerment is women's financial autonomy. And this was measured through 3 questions, asking if women had any savings for the future, if they knew where to go for financial information or advice, or if they had any financial goals towards they were working on. And this variable was also constructed in a binary form. Now, for today's presentation, I'm only going to be focusing on presenting the preliminary results for our first domain. Because of time, we would not be able to cover both of them. So I'll start on the next slide just by sharing some of the distribution of household decision-making levels across the 8 PMA sites, both reported cross-sectionally in 2019 and 2020. Now, what you're seeing in this figure is that each bar represents the percentage of women who reported that whether they participated in none of the decisions, which would give them a value of 0, and the proportion of women who participated in 1, 2, 3, and as high as participated in all 4 decisions. One of the key takeaways from this figure here is that we see that there are notable variation across the sites and somewhat over time. For instance, in Kenya, and Lagos and Kinshasa, we see that those 3 sites reported the highest share of women that reported that they participated in all 4 decisions, while in Niger and Kano, they reported the highest proportion of women who reported not participating in any of the decisions. The highest was in Niger in 2019 at 67%. Just to reiterate is that this comes from the cross-sectional samples collected both in 2019 and 2020. Now, in the next one of the first questions that we wanted to understand when we started doing this work is, once we validated the scale, we are interested in understanding or identifying what are the correlates of women's decision-making, either when those decisions are made by themselves or with their partner. And we wanted to identify a set of covariates that predict the level of empowerment. We selected our covariates following the conceptual framework proposed by Sunita Kishore. And overall, we identified 4 levels that are relevant for economic empowerment. These are at the individual, at the marital, household, and community levels. What you're seeing in this table here are the results from our regressions in which the outcome of interest is our household decision-making scale that ranges from 0 to 4. The results that you're seeing here come from the cross-sectional sample collected in 2019, and women who are included in the sample are those who reported that they were either married or living with a partner and were of reproductive age between ages 15 and 49. One of the key takeaways that comes out of this table is that we see that there is a positive relationship between age and having higher levels of economic empowerment. This is a significant relationship in 6 out of the 8 sites, in which older women reported to have higher levels of household decision-making compared to younger women. We also found that education showed a positive relationship with higher levels of household decision-making in 5 out of the 8 sites. The exceptions were Kinshasa, Niger, and Kano. Similarly, we also find that the number of children, it also shows a mostly positive association, as it was positive in half of the sites. It was positive in Burkina Faso, in Kinshasa, Congo Central, and Kano, and it was negative in Lagos. We also find that wealth was positive in 3 of the sites, in which wealthiest women reported higher levels of household decision-making compared to less wealthy women, and this relationship was negative in Lagos. The ones that are interesting to look at are the community level variables. The way that we've constructed these variables is that we were able to measure the proportion of women who, within the cluster where a woman resided, had completed secondary education, and also the proportion of women who within the cluster reported that they were working over the past 7 days. What we find for secondary education is that there was a significant positive association with household decision making in Burkina Faso, Cote d'Ivoire, Kenya, and Kinshasa, which suggests that women living in communities with a higher proportion of women who have completed secondary education are more likely to report greater involvement in household decision making themselves. Now, I do want to make some exceptions here that you will see that the patterns shown in Burkina, Cote d'Ivoire, Kenya, and Niger are more alike, while the patterns shown in Kinshasa, Congo Central, Lagos, and Kano are slightly more different, which may be that this is indicating that there is a unique socioeconomic dynamic in those sites, and it might be also the fact that those are regional data instead of the other ones that have national representation. Now, the results I'm sharing in this slide, they are not entirely novel. There have been other studies that have already examined the correlates of women's economic empowerment, particularly on when we think about women's household decision making using cross-sectional data such as the DHS. Our contribution to the women's economic empowerment literature is more along the lines that we're leveraging the longitudinal data collected by the PMA project, which allows us to capture changes in empowerment over time and explore the predictors of both gains and losses in a way that cross-sectional analysis cannot do that. So in the next slide, I do want to spend some time to illustrate these changes. Now, I'm not showing any data. This is just an illustration of how we can measure these changes. So here you're seeing a heat map that illustrates these changes in household decision-making power over a 1 year period. Now, as you're seeing here, we have the reports that are reported at baseline and then at follow-up. In the x-axis, you're seeing the reports, the level of household decision-making reports reported at baseline, and then in the y-axis, you're seeing the reports made at follow-up. Now, each cell in the grids represents a direction of change for women between those 2 time points. The positive sign, which is in pink shade, indicates an increase in decision-making power. The negative sign, which is in purple shade, indicates a decline in decision-making power. Now, the gray cells suggest that there has been no change in the scale. The color intensity in this heat map reflects the magnitude of change. Darker shades represent larger gains or losses, while lighter shades represent smaller changes. I hope this illustration clarifies how we are keeping track of the changes in the levels of household decision making over time. And leveraging this data, some of the questions that we intend to answer in our analysis are: to what extent does women's economic empowerment changes over time? What are the baseline factors that can predict this change? And what are the baseline factors that can promote gains in economic empowerment? Thanks, Caroline. Now let's take a look at the changes in household decision making over time. Now, the figure that you're seeing here is using the longitudinal or the panel data collected 1 year apart. So we're looking at the changes that took place between 2019 and 2020. This figure shows the distribution of change in household decision making power among women across the 8 PMA sites over a 1 year period. Each bar represents a country or a site, and the segments within each bar represents the different patterns of change. Remember that the gray segment represents women whose level of decision-making power stayed the same, and that the pink shade reflects gains in decision-making power. The purple shade represents losses. And remember that gains and losses can range from 1 to all 4 decisions areas. Now, darker shades within the pink and the purple, they indicate a greater number of decisions either gained or lost. Now, in this figure here, you're also going to notice that there are green segments at the top, and at the bottom of each of the bars. And those green segments represent women who either gained or lost a partner, which we are not able to include in our longitudinal analysis because the question of household decision making is limited to those who report being in a partnership. So we wouldn't be able to follow their changes over time. Now, what stands out from this figure is that you see that the gains and the losses are not negligible across the sites. You can see that about 1/3 to half of women experience a change in their level of household decision making, which underscores the dynamics of the dynamic nature of empowerment. The proportion of women who maintain the same level of decision-making power range from 29% in Côte d'Ivoire to 51% in Niger. Now, again, the key takeaway here is that women's household decision-making power is not static, it shifts over time, and these changes differ by context, which suggests the importance of longitudinal data to fully understand these empowerment trajectories. Now, in the next slide, we started with a similar analysis to the one I showed on the cross-sectional, using the cross-sectional data, and we wanted to understand whose power grows and whose power falls, and by identifying what are the correlates of changes in household decision making. Women who are included in this sample are those who participated at both survey rounds in 2019 and 2020, being part of the panel. Those who are of reproductive age that reported being either married or living with a partner at both times of the interview. As you can see here, we limited our analysis only to the sites where PMA has nationally representation because of the limitations that we've identified in our cross-sectional analysis, and also because we were limited in sample size. So we ended up including Burkina Faso, Cote d'Ivoire, Kenya, and Niger. The results that you're seeing in this table are coming from logistic regression models in which the outcome of interest for this first table was that the report of increasing or gaining empowerment in the household decision-making scale compared to staying the same. As in the cross-sectional analysis, the set of covariates that we selected were those that we also identified in the cross-sectional analysis, and includes factors at the individual, marital, household, and community levels. And all of these were measured at baseline. Now, the goal of this analysis, once again, was to identify whether certain baseline characteristics are associated with women's gains or losses in household decision-making power over time. In other words, if we can identify attributes that can serve as protective factors against losses in empowerment or that promote empowerment or gains over time. So one of the factors that highlights here, or that is worth emphasizing, is age, in which we found that in both Burkina Faso and Cote d'Ivoire, older women had significantly higher odds of gaining empowerment compared to younger women. In Cote d'Ivoire, we found Kenya and Niger, we found that women from wealthier households were more likely to experience increases in empowerment relative to those from less wealthy backgrounds. Interestingly, we still find that community context matters, similar to the cross-sectional analysis, and we found that in Kenya and Niger, a 1% increase in the proportion of women in the community with secondary education, as well as a 1% increase in women's labor force participation, was associated with a higher likelihood of empowerment gains. And then the next results are those when the outcome of interest is losing empowerment compared to staying the same. And I'm not going to go into the details of this table, but what you can see here is that the factors that we identify as positively correlated with gains are negatively correlated with losses. Not in all cases, but in many of them that those factors remain statistically significant, but with a different relationship in the sign. Now, in the next slide, I'm not going to explain this figure in detail because of time, but I just wanted to bring this up because I do want you to go with the key takeaway from here is that the baseline level of women's economic empowerment matters for experiencing changes in either gaining or losing empowerment. As you can see in this figure, we somewhat found a gradient across the PMA sites. And it's interesting that this gradient is also related with those women who maintain their same level of empowerment based on their baseline level of economic empowerment. Now in the next one, because I'm almost running out of time, I just want to finish with some of our key takeaways. So in this presentation, we examined the changes in women's household decision-making over a 1-year period. We found that empowerment levels, they vary largely by context and also over time, with a proportion of women reporting no change ranging from 29% in Cote d'Ivoire to 51% in Niger. Individual characteristics such as age, education, and work were associated with empowerment, while community level factors, including the prevalence of secondary education and women's labor force participation, also play an important role. Also, that baseline levels of empowerment seem to shape both gains and losses. Now, moving forward, our analysis intends to explore the empowerment gradient I showed in the last slide, and we intend to focus on those women who began at intermediate positions, ranging from the scores 1 to 3, and explore further the role of each of the decision-making activities, which I did not show in this presentation. We're also interested in understanding this relationship is whether contraceptive use empower women, or is it that empowered women are more likely to use contraception? And this goes back to the question that Linnea posted earlier. What happens first? Is it the chicken or is it the egg? And disentangling this relationship is challenging. And ideally, one would like to have an external shock or an experiment to be able to disentangle this. But it is not always realistic to have this, so we need to approximate this causal inference with causal inference methods in order to address and disentangle this relationship. So with that, I'm going to stop here and pass it over back to Caroline.
Thank you, Carolina. Thank you, everyone, for sharing your insights on some of the drivers and the implications of empowerment. As kind of we wrap up this two-part webinar, I want to leave you with I would say probably four key points. The first is that our research provides robust empirical evidence that empowerment matters in promoting health and well-being of women. And therefore, we should continue investing in programs to support women's autonomy and access to essential resources to jointly improve their health and development outcomes in low resource settings. The second point I'd like to make is underscoring the importance of developing conceptually grounded measures of empowerment that distinguish different dimensions. We talked about sexual and reproductive health. We talked about economic empowerment, and even in the sphere of sexual and reproductive health, we distinguish sexual from contraceptive empowerment. This is important because women may be empowered in one sphere of life, but not necessarily in all spheres of life. We also learned that the empowerment framework is really important in thinking about how empowerment operates. Which acknowledges not only the role of agency, but also the opportunity structures, such as education, wealth, or the healthcare system, in enhancing women's autonomy and ability to make choices that are related to their sexual and reproductive health. The third point is that programs programs need to account for the local realities. As empowerment, we saw changes depending on context and varies across settings. And so it's really important to prioritize local insights and qualitative research, both when we develop measures, but also when we tailor programs to the changing circumstances of women over time and across context. Finally, I want to stress the critical role of global data platforms, such as the PMA platform, that enabled and is uniquely positioned to efficiently deploy this kind of global effort. It's a global collaborative effort to innovate and scale up measurement for monitoring and evaluation. And as we enter in an era of uncertainty related to global data, I think this example stresses the importance of supporting existing networks that leverage existing skills, as well as demonstrating capacity to efficiently support programming and innovations. This work continues. And as at the Gates Institute, our work continues in uncovering and understanding empowerment across the life course. With efforts, some driven or led by Linnea Zimmerman in looking at how empowerment emerges in early adolescence and support their health as they transition through adulthood. We're also invested in understanding how the role of empowerment is a protective factor against reproductive coercion, again, using the PMA data, and this work is very much led by Shannon Wood. We also want to expand the concept of empowerment not only as being an individual, but also a dyadic perspective in exploring how empowerment is experienced, enacted, and constrained within relationships. Finally, I think as one of our audiences has asked, we hope to partner with public health practitioners to use this data efficiently to guide programs at the local level, but also monitoring how women's empowerment might change over time and might be boosted by programs that target women's autonomy and ability to make choices and act on them. As one example of our research's investment is this newly NIH-funded project with PMA partners in Burkina Faso, where we adopt a dyadic perspective to look at women's empowerment within relationships, and we build on Linnea Zimmerman's work, thinking about how existence and exercise of sexual and reproductive health both might reduce the intention gap between fertility intentions and contraceptive intentions, what we've qualified is the demand side, as well as the behavioral gap between contraceptive intentions and contraceptive use. Finally, I am leaving you with a number of additional resources that support some of the work or reflect some of the work that we presented today and expand on these different themes. And finally, I would like to leave you by thanking all of our partners, starting with all of our global PMA partners, our data collectors, our faculty at Hopkins, our students, and importantly, a personal thank you to Amarachi Yojoma from the Gates Institute, who helped us coordinate all of this work and will make these webinars available for you to vision in the next few days. And let me turn on time. We just have 1 minute. You are very welcome to reach us at the Gates Institute if you have any questions. And thank you so much for your attention.